Hi, my name is Abhishek Deshmukh, one of the electrophysiologists at Mayo Clinic. And today I'm going to talk a little bit about specific ECG patterns in certain specific congenital heart disease. So this is part 2 of our series. In the first part, we talked about predominantly atrial septal defect. And here we'll talk about few other specific lesions. I have no disclosures, and I would like to acknowledge Dr. Edwards for maintaining an incredible library of pictures and specimens of patients with congenital heart disease. This is an ECG of a 25-year-old female with recurrent palpitations. The arrhythmia was not caught so far, but she came to the clinic, and this was her ECG. So sinus rhythm, leftward axis, maybe suggestion of something interesting here, maybe a delta wave or so, but kind of an abnormal ECG for somebody who is 25 with presumed normal heart. Well, presumed normal heart is presumed until the time we get an echocardiogram, and this is the echocardiogram. So you'll see there is significant right atrial enlargement, severe tricuspid regurgitation, and almost looks like a sail-like anterior leaflet of the tricuspid valve with more posterior displacement of the annulus. So this is suggestive of EPsteins anomaly. Now what happens in EPsteins anomaly is that due to lack of delamination, the posterior and the septal leaflet get attached to the myocardium, and then there is downward displacement of these leaflets, because of which the true annulus is present, but there is also a creation of this functional annulus because of the downward displacement. And that results in a atrialized right ventricle. So because of this entire structure becomes a ginormous right atrium, and that is kind of a telltale sign in patients with EPsteins anomaly. So when we look at an ECG of a patient with EPsteins anomaly of the tricuspid valve, a common teaching point is they have Himalayan P waves. That's because of that significant right atrial enlargement what we saw. Right bundle branch block. These patients are prone to develop multiple atrial flutters, SVTs, and they are also known to have multiple accessory pathways. So this is an example of those Himalayan P waves. P wave is significantly enlarged, right atrial enlargement, and kind of suggestive of a tall mountain peak. But it's not always true that patients with EPsteins will have Himalayan P waves or a very, very tall P waves. Now the reason why these tall P waves happen, because the entire right atrial chamber is this big, and that creates initially a vector which is very positive, and that's why we get such a big P wave. But imagine if this right atrium has enlarged and has scarred out, the right atrium may not be able to make such a big voltage for a P wave, and that P wave over a period of time can become diminutive. So if you follow a course of ECGs in patients with EPsteins anomaly, it is not uncommon to note that the P wave amplitude actually decreases over a period of time. Right bundle branch block is a rule in patients with EPsteins anomaly, because the conduction as it goes from atrium to the AV node His bundle, because of this significant enlargement of this chamber here, this normal right bundle gets lost and gets very diminutive and blocks. Because of which the conduction goes down the left side, LV, and then crosses from the interventricular septum and then activates this chamber of the right ventricle. Now this takes significant delay and conduction delay. That's why you get this right bundle branch block in patients with EPsteins. But if you don't have a right bundle branch block, think for sure the patient has accessory pathway, because the time it takes to go all the way down the left bundle, LV septum, turns back around the septum and activates the right ventricle. If there is a shortcut or a bypass pathway or an accessory pathway through which the activation can go down, it's going to take that path, and then you would have a ventricular activation because of the presence of this accessory pathway. So if there is no right bundle branch block in a patient with EPsteins anomaly, there has to be an accessory pathway, and therefore right bundle branch block is almost a rule in patients with EPsteins anomaly without an accessory pathway. Now these patients, because of this significantly diseased annulus, are also at a risk for developing multiple accessory pathways. So there may also be certain variation in the QRS without a right bundle branch block. And if you see different levels of fusion, then start to think there might be another accessory pathway which is located. Now coming back to our patient, so this patient actually had a posterolateral accessory pathway, and after ablation, the pathway is gone, and now you get a right bundle branch block pattern. Again, important to know that the right bundle branch block pattern is present. If it was not present after the ablation, think there's another accessory pathway, and that needs to be mapped and ablated as well. This is also an example that here you don't see those giant or Himalayan P waves, so that's why presence of those P waves is not certainly very specific that you would have EPsteins anomaly, and this does suggest that the right atrium is significantly enlarged, more diseased, and the right atrium contraction is just not able to make that big of a voltage to create that big P wave. Now, the patients with severe EPsteins can also have slowing of conduction. So we talked about this image, and there is, because of so much delay and scar in this location, the conduction can become fairly slow and delayed. Now this gets manifested on ECG in the presence of these multiple QRSs or notches. So you have a P wave, then you have a R, S, R prime, S, and then you get the T wave. Effectively, you're almost having two separate QRSs which are noted. Now, this is again seen in patients with EPsteins or any patients with significant scar in the heart because of just slowing of conduction. Another clue, as you saw, that the PR interval is slightly longer. So in EPsteins patient, there is really no problem with the AV node, but because the PR interval is the summation of time from the onset of atrial depolarization to the ventricular depolarization, as the duration of atrial depolarization is very long due to significant slowing of conduction, sometimes you can get this longer PR interval in patients with EPsteins anomaly. It is also not uncommon that because of this scarring, you get these multiple notches, and this can also be a predictor that these patients might be at a risk for ventricular arrhythmia, specifically ventricular tachycardias. So in summary, for EPsteins anomaly, right bundle branch block is the rule. If there is no right bundle branch block, think there is an accessory pathway. Sudden death is definitely possible, and it can be possible because of pre-excited atrial fibrillation or atrial flutter, multiple accessory pathways. And if the QRS has significantly prolonged with a lot of fragmentation and fractionated QRS as we saw, they are at a risk for having ventricular arrhythmias. We'll switch gear to this ECG now. 32-year-old young lady with syncope. And as you see this ECG, you would see that there are Q waves in the inferior leads, but the patient probably never had an inferior wall MI. But one interesting thing is that there is no Q waves for the septal leads. So normally you would have left to right activation, and that would show up as small septal Q waves in lead 1 AVL V6, but you are not having those Q waves. So what might be going on here? So no septal Q waves and Q waves in the inferior leads start to think that maybe the activation in the heart is different, and maybe the patient does not have left to right septal activation. Once that happens, we need to dig more in deep to see what might be going on. So normally, activation happens from the ventricular depolarization happens from apex to the base, and then from endocardium to epicardium. And the septal activation happens from left to right, and that's why we get these septal Q waves in leads 1 and AVL. In certain congenital anomalies, transposition of great arteries, there is some mismatch in the position of the ventricle and position of the great arteries. So let's look at that. So normally, ventriculo-arterial connection is that the RV sends blood to the pulmonary artery and blood goes to the lung. And the left ventricle sends blood to the aorta and that goes to the rest of the body. So this is called as normal connection or concordance. If there is a discordance in this ventriculo-arterial connection, that would mean that the right ventricle, instead of sending blood to the pulmonary artery, is sending blood to the aorta, and the left ventricle is sending blood to the pulmonary artery. That is going to be transposition, and that is going to be discordance. So this is ventriculo-arterial concordance, ventriculo-arterial discordance. There can also be atrioventricular concordance and discordance. So normally blood goes from right atrium to the right ventricle through a tricuspid valve, and from left atrium to the left ventricle through a mitral valve. But in discordance, the blood will go from right atrium to the left ventricle, and then from left atrium to the right ventricle. So this is going to be discordance, or the ventricles are inverted. What happens in patients with congenitally corrected transposition is that there is a double discordance. So the blood, instead of going from right atrium to the right ventricle, goes from right atrium to the left ventricle. And instead of the blood going from right ventricle to the pulmonary artery, the blood goes from left ventricle to the pulmonary artery. So you have AV discordance and VA discordance, atrioventricular discordance and ventriculo-arterial discordance. Now, whenever there is this discordance, the bundle branches follow the ventricles and the valves also follow the ventricles. So if the left bundle comes here and the right bundle comes here, the septal activation is going to become from right to left rather than normally left to right. How does that get manifested? Normally, if the conduction of the septum or septal activation is happening from left to right, you get a small Q wave in the 1 and AVL. But here, you don't get that Q wave because the activation is happening in the opposite direction. So the septum is getting activated from right to left. That's why you don't get these Q waves. But those Q waves get manifested in the inferior leads. Now, why it is important to identify this defect, as patients with congenitally corrected transposition of great arteries are at a risk for high degree and complete heart block. And they can present with syncope, they can present with multiple arrhythmias. Another unique thing about congenitally corrected transposition of great arteries is the presence of accessory AV node. So normally we know that the AV node resides in the AV septum, but in certain patients, especially those who have a little bit of hypoplastic or atretic pulmonary artery, you could, at the level of the pulmonic valve, there can be another AV node, and these two AV nodes can connect with each other through a sling called as Mockenberg sling. And these can be implicated in various very complex AV-NRT tachycardias. So this is an example where you have two different morphologies of tachycardia going on. Again, this was kind of a tachycardia involving both the AV nodes in a patients with CCTGA. So in patients with CCTGA, they are at a high risk of AV block. PR interval, if variable, start to think of accessory AV node. Again, variable QRS is possible. These patients are likely for a risk of SVTs, and there's a risk of sudden death if the right ventricular ejection fraction is less than 35%. But again, the main clue for noting this would be if the septal activation is not from left to right, then at least in your mind you have to wonder whether there is a CCTJ going on. And this condition again can be missed as the child is growing up and can certainly be picked up in the adult life. Lastly, we'll talk about this again, another common condition. So 45-year-old male who is just getting scheduled to see you for follow-up of maybe other medical or cardiac issues, but you see the ECG here. So we have spent a lot of time looking at right bundle branch blocks, or right bundle branch delays, but this is even more unique. You have R, S, R prime with multiple other notches which is noted in this R prime. So let's look at tetralogy of Fallot. So what happens here, that there is a defect in the infundibular septum that results in pushing away of this septum more or this tissue more anteriorly. That causes obstruction of the right ventricular outflow tract. And any obstruction is going to cause pressure overload. That's why the right ventricle enlargement and hypertrophy. And then there is overriding of the aorta. Most of these patients get an intervention in the right ventricular outflow tract, either ventriculotomy or a patch or something like that. So they, as a rule, or majority of them, 95% plus patients after an operation for tetralogy of Fallot will have a right bundle branch block pattern. Now the important thing for us to note is that there is no real good criteria for diagnosing right ventricular hypertrophy in patients with a right bundle branch block. And the only clue can be the R prime amplitude. So if the R prime is tall, start to think that there is right ventricular hypertrophy in a patient with right bundle branch block. But even more so important in patients with tetralogy of Fallot, as you follow them serially, if this R prime starts to get shorter and shorter and shorter, think that the RV is failing and they may need urgent intervention, and that may be even present even before the symptoms can sometimes occur. So just a clue when you're following these patients over a period of time, pay attention to the R prime, because if that R prime starts to go down, then they might be at a risk of overall RV failure, and they may need more therapies. Now, we don't normally see this, but in a patient with unrepaired tetralogy of Fallot, again, because of no surgery, there is no right bundle branch block. But again, because the lead V1 is close to the outflow tract, there is significant disease there, narrowing, slow conduction. That's why you get multiple notches here suggesting of a slow conduction in that area. So typical findings of tetralogy of Fallot ECG are going to be right bundle branch block repaired, risk of VT. Generally, if the QRS is more than 180 milliseconds, they are at a higher risk for having ventricular arrhythmias. And wide QRS with fragmentation, like we talked in EPsteins, again is a marker that these patients might be at a risk for ventricular tachycardias. And certainly pay attention to the progressive QRS change. Specifically note the R prime. If the R prime starts to get shorter and shorter compared to earlier ECGs, then think that the RV might be enlarging or failing, and something to think about and manage. Now, when you look at spectrum of arrhythmias in patients with congenital heart disease, the atrial arrhythmias could be surgically related to the cannulation site or the atriotomy site or ASD patch or some sort of repair, or even the common cavo-tricuspid isthmus. The ventricular arrhythmias could be because of VSD patch, outflow tract scars and reconstructions like in tetralogy of Fallot, and any other ventriculotomy which might have been performed. Another important tachycardia which shows up is this intra-atrial reentrant tachycardia. This is one of the most common tachycardias in patients with congenital heart disease. This is due to presence of a large circuit or a reentrant circuit seen in a lot of patients after Fontan operation or in patients following mustard and Senning operation. Thromboembolic complications can arise if these episodes are protracted, and there is a risk of sudden death. Now, atrial arrhythmias is a marker of sudden death in some of these patients, because what happens is that if when the rates are very, very fast, they generally tend to have 1-to-1 conduction, or even if they have 2-to-1 conduction, because the rates are very, very fast, that creates RV failure and then ischemia, VTAC, and VFib. So that's why atrial flutter is an independent predictor of mortality in patients with congenital heart disease. So in summary, pay attention to the right ventricle and all the changes in right ventricle on an ECG. If there is no right bundle branch block in a patient with EPsteins anomaly, think there is a pathway. Patients with CCTGA are at a higher risk of AV block, but at least think that if the septal activation is not left to right in a young patient, wonder whether there might be congenitally corrected transposition of great arteries. And a QRS more than 180 millisecond in patient with tetralogy of Fallot, that is high risk for VT in these patients. So I think I'll stop here and hope this primer kind of helps you to identify some of these patients, risk stratify some of these patients with congenital heart disease, and hopefully this is helpful for you in taking care of our patients. Thank you very much.